literature. There's always been some controversy there, particularly in the setting of craniotomy for temporal lobectomy. The consensus has always been that acute postoperative seizures are not predictive, and we generally tell patients if you have a seizure in the first 2 to 4 weeks after an epilepsy operation, don't worry. It's not necessarily predictive of failure. But I think Ariana is going to show you some data that puts that in the question for laser ablation. Thanks, Ariana.
Thank you very much, Dr. Allenbaum and Dr. Outman. So good morning, everyone. My name is Ariana Barkley. I'm currently one of the PGY7s. I'll be presenting on one of my clinical projects, evaluating acute postoperative seizures and angle class outcome at 1 year, post-hippocampal laser ablation for mesial temporal lobe epilepsy specifically. It's a question that actually arose during a case with Drs. Houtman and Ojman during my chief rotations, resulted in some interesting answers. So just to give a little background, the intro of MRI-guided laser interstitial thermal therapy, or MRG-LIT, for epileptic foci was actually first described by Curry in 2012. And after Sugiyama had published on its use treating deep-seated brain tumors, it's been adopted as an alternative to surgical resection for select patients with drug-resistant epilepsy, and subsequent studies have demonstrated promising results with freedom rates around 50 to 70% at 1 year. And reports of improved neurocognitive outcomes compared to our open surgeries like ATLs. Studies addressing surgical resection suggested that the predictive factors include postoperative seizure freedom, predictive factors for postoperative seizure freedom may include like epileptic duration, prior to intervention, age, and semiology. But the occurrence of APOS has been implicated as an adverse predictive factor for seizure freedom in our open surgeries, but there haven't been any studies to our knowledge that address the prognostic value of this in MR-guided laser interstitial thermal therapy. So we had defined acute postoperative seizures in the context of this study as within the first week, but as the literature has defined it, it can be within 7 to 30 days. And reported values after epilepsy surgery have been anywhere from 5 to 50% and tend to be correlated with worse long-term postoperative seizure freedom. So we evaluated whether this was the case in MRI-guided LIT. So for our review, we included all patients who underwent hippocampal laser ablation between 2010 to 2019. So 9 years. Inclusion criteria was age over 18, first time ablation for specifically medically refractory epilepsy, and the preoperative variables are listed there. We did age and onset, duration, average seizure frequency, number of anti-epileptic drugs trialed and failed, and then whether there was an actual lesion that was verified radiographically. Our postoperative data included the side, the hippocampal and amygdalar residual volumes. We're currently working on the ablation volumes, and presence of clinically detected APOS is defined by like reported events within the first 7 days, not necessarily verified by EEG. And we processed our MPR RAGE imaging using FreeSurfer in order to look at the residual volumes for the amygdala and hippocampus. So in total, 121 patients were included in the study over these 9 years. 53% were female. Average age was 21 at the onset of epilepsy, with an average preoperative epilepsy duration of 22 years, plus minus 15 years. Seizure frequency was about 5 episodes per week, and patients had actually trialed at least 6 anti-epileptics on average prior to surgery. So 66% of them had had a generalized seizure semiology, and a radiographic lesion was present in about 82% of patients. So it did appear that a radiographic lesion at the ablation site correlated with a lower angle class outcome, so increased seizure freedom, with 41% of patients who had a detectable lesion compared to 16% of those without a radiographic lesion reporting an angle class of about 1. But the significance actually disappeared after we adjust for generalized semiology, duration, and presence of an acute postoperative seizure. So as you can see here too, neither sex, age and onset, failed number of anti-epileptics, or seizure frequency appeared to correlate with their angle class outcome. Although generalized seizure semiology did appear to correlate with a higher angle class outcome postoperatively, so less chance of seizure freedom. Looking at the postoperative data, about 34% of patients experienced a clinically detected acute postoperative seizure, so within 7 days post-op. In total, there was a 38% angle class 1 outcome at 1 year, 6% class 2, 27% class 3, and 29% class 4. APOS occurred in only 14% of patients who ultimately were seizure-free, but occurred in 50% of patients with class 4 outcomes at 1 year. So having an APOS therefore gave a patient an odds of having an angle class 4 outcome that was 6 times higher than that of an angle class 1, even when controlling for seizure semiology, duration, presence of an anatomic lesion detected on MRI. So those other factors that we saw were significant. About 108 patients, so 89%, had post-ablation imaging that we could technically use for volumetric analysis, and residual amygdala volume did not appear to correlate after adjusting for multiple comparisons, but residual hippocampal volume did exhibit a trend towards a lower angle class with a residual volume nearing 2 centimeters cubed. But this also did not remain statistically significant after we adjusted for multiple comparisons. So this is just another visual of the relationship between APOS, which is in orange, and angle class at 1 year. You can see a class 1 outcome. There's significantly less patients who had experienced an acute postoperative seizure compared to class 4. So just in concluding, MRI-guided laser interstitial therapy for hippocampal ablation is a relatively new method of treating medically refractory epilepsy, and obviously further evidence is required to determine more prognostic factors related to postoperative seizure freedom. But in the context of our study, we found that a lack of acute postoperative seizures, defined as within 1 week, correlated with an angle class outcome at 1 year. Smaller post-ablation hippocampal, but not necessarily amygdalar volumes, exhibited a trend towards better outcomes without a sustained statistical significance. And preoperative factors that also correlated included a radiographically detected lesion on MRI, though the significance of that also was removed after taking into account APOS, meaning that this may be one of the factors that kind of outweighs the rest. So
that's wonderful, really. Now let me ask you the first question,
yes.
and then please cut me off, Julie, if we go over. Did you start this when you were doing your last rotation, when you were covering, or when did you start this research? It's nice.
Yeah, so I started it actually when I was on my chief rotation, okay. And so last year. And then we, I think, pulled about 140, 150 or so patients that we had done laser interstitial thermal therapy on for the last 9 years. And then after sorting through that, about 121 patients were just for mesial temporal lobe epilepsy. And we'd actually completed a lot of the statistical analysis with the help of Dr. Barber, and then Liam and Alec, who are medical students, assisted with the chart reviews. But the processing of the imaging in order to make sure that the amygdalar and hippocampal volumes weren't confounding factors is something that we're finishing up right now. So hopefully within the next week or so, we'll be able to actually submit.
Good, beautiful. We have time for one last question. We're at the 12-minute mark. That was wonderful. Thank you.
I have a brief question.
Okay,
this is Dan Silverdale. I'm just curious, and I don't know if you can answer this. You may need help from the docs you did it with, but when you go back on the failures, what tends to be the site of failure for these laser ablations?
Meaning when
you put a grid and strips in, and you're going to re-op because the patient's still having seizures. Where do the seizures typically arise from?
Oh, I mean, that's a good question. I didn't actually look at the failures where their where their epileptic focus was. The failures were mainly like if they had their prior seizures that they had initially presented with, similar semiology or a different semiology, and I honestly didn't look at their subsequent like grids and strips and workup for that.
Yeah. So we'll just cut to the chase. Jason, do you want to make something up for that answer for Dr.
Yeah, I'm totally happy to make something up. Dan, that's actually a really great question.
Yeah.
And I think that we haven't really looked at that. Not every patient who fails laser ablation goes on to a phase 2. Some just kind of linger out there. Some will get reablated and have an improved outcome. And then some will go on to phase 2. I suspect that the answer to your question is actually related to some of the things that Ariana found, such as non-lesional, longer duration of epilepsy, generalized semiology being related to poor outcome, likely implicating that it's not mesial temporal or it's mesial temporal plus. I think would be the most likely explanations, for those failures. But no one's actually looked at where they fell from.
Good. Thank you very much. All right. Next up, great job, Ariana. Next.
Sorry, I was just going to add one thing. Sorry, I was on a phone call, so I missed some of that first part. But for this project, we actually did look at semiology and all this for the same patients. It's just in a different paper. We're working on it.
Okay, thanks.
But not for spread stuff. Yep.
Yeah, Andrew, you sound like you're in a traveling underground somewhere. Thank you, though. I'm glad you're here to be here. So the next paper is by Sam Emerson, MD, PhD. He went to USC, got a degree in engineering, minored in water polo, and then went on to the University of Washington, where he got his PhD in Phil Horner's lab on neurostem cell progenitor cells for spinal cord injury. And he's the chief resident in our residency. He's going on to the Brigham to do a fellowship in skull-based neurosurgery. Wonderful resident, married just an absolutely lovely neuro-ICU nurse named Gracie. And of course, that's the most important thing he's done in the 7 years he's here or 12 years he's here. But Sam has done some great work. He's on the R25. He was awarded an R25. You want to tell us a little bit about who you're working with Dr. Patel, is that correct? On this particular?
Yes, this was work done in the Patel lab and a little bit with Eric Collin.
Eric Collin.
Yeah.
And anything you want to add, Anoop?
Sure. Yeah. Thanks for the introduction for Sam. I'll just make a couple of brief comments, which is that we built this project around some of the really incredible work that Sam had done during his PhD, and taking advantage of his experience with working with ES cells and doing directed differentiation that he had really mastered during his PhD. And so we're able to kind of pull him away from regenerative spinal cord injury and pull him into the tumor world. And so he's going to present some of his work on that today.
Yeah, thank you for the introductions. It was very easy to pull me away from the spinal cord injury stuff, but I remember distinctly hearing Dr. Patel's talk during his fellowship time and thinking that it was very exciting stuff and something I wanted to be a part of. So I appreciated him welcoming me and mentoring me on that. So real briefly, I think a lot of the background stuff I'll go through very quickly for the sake of time, but we were trying to create a model for GBM in particular, something that recapitulated the known heterogeneity of the disease, because it was felt to be a pretty big contributor to why GBM is so refractory to maximal multimodal treatment, and that there must be some part of the disease in the tumor that we're missing. And a lot of that we felt was informed by the local microenvironment and the dynamic interplay between the host tissue and or the native normal tissue and the tumor, and that really the the tumor themselves is quite heterogeneous in space, with different niches being formed, kind of at the leading invasive front, as well as in the central necrotic core, and in the paravascular spaces. This heterogeneity was well described by Dr. Patel a number of years ago with his single cell work, characterizing multiple different cell types that exist within the tumor. And again, this is a fairly dynamic state, because the sort of evolution that the tumor undergoes is a reversible process, because it's largely driven by epigenetic and transcriptional factors. And so you can see that when you take different samples from the same tumor, from different phases, that the transcriptional profile will vary markedly, and the way those cells behave is very different. And a lot of the current models, don't, we think, really, capture or faithfully recreate that. So that's basically what we were trying to do, was form an ES and IPS cell based in vitro model that was really like a three-dimensional avatar for the disease that would be able to recreate that some of those interactions a little bit better. This is a bird's eye view of a kind of a differentiation protocol, but suffice to say that it's a largely sort of hands-off approach, in that you start with single cells of ES cells, and basically through a series of culture manipulations and things that media, as well as some dynamic agitation, try to recreate this three-dimensional, very specifically pattern crude version of a brain in a dish. And so when we do that, we get these very nice large organoids that form a lot of neural tube-like structures that we can see in a variety of ways, form an in vitro representation of the brain. And you can see these are just a sort of sequential phase series of these organoids. And you can see even at the very low magnification, all of these basically neural tubes essentially trying to be formed. And so we did a lot of immunohistochemical staining to characterize these, and we see a lot of the same developmental patterns that we know exist in normal development, both from temporal and spatial perspective. So starting over the order of the first 2 to 3 months, you see development of excitatory layer neurons, and in an order that recapitulates development with it follows an inside out patterning, where earlier neurons form these sort of inner layer neurons, like they're CTIP2 positive, and then these sort of taper off with time, and they're then replaced by STAT-B2 outer layer neurons. And in glia, using a GFAP marker, take more on the order of 3 months or more to start showing up. And again, this is very similar to development, where neurogenesis precedes gliagenesis. Those glia do eventually form up, but it takes several months. But then we do see more mature markers like the GFAP, S100 beta, and HOPX. It's something that takes quite a bit of time to actually start showing up. We also, as I mentioned, see a lot of the similar spatial patterning in terms of the organization of these neural tube-like structures that we call rosettes, but where you have similar architectural arrangement to the ventricular zone and subventricular zone, where in the inner layers you have neural stem cell markers like PAX6 and SOX2, and then out of the periphery you have immature interneurons that are TBR2 or beta tubulin positive, sort of radiating outwards from that zone. And then this again is very similar to development and kind of what you would see surrounding the ventricles, even in the adult brain. So we tried a few different ways to make a GBM de novo in these organoids once they were something that we felt like was mature enough to potentially host a tumor. And we did this through a variety of in vitro manipulations that included both P10 deletion as well as addition of growth factors. We're trying to use sort of the big gun, more well-characterized drivers of GBM formation, as well as using some of the Holland Lab numerous constructs through their ARC-S TBA system, where you use single hairpin constructs against some of the more commonly known markers like P10 and P3. And when we do that, we get pretty dramatic effects, even just from a simple manipulation like knocking down P10. When we start making these organoids, within a few days, we see dramatic differences in size and heteroarchitectural organization, where they get profoundly larger and within the first week. They still express a lot of the same, neural stem cell markers that we see in the wild type organoids, but they definitely have structural abnormalities. Instead of forming those nice ovoid rosettes, they tend to form more finger-like projections and just lose some of that regularity even within the first few weeks. They also, as you would kind of expect, show a higher mitotic rate, are dividing a lot faster, and some of those nice demarcations that you see between the various layers of the developing rosette sort of get lost. And you can see on the left, where we have those nice sort of clear delineations between the neural stem cells and the immature neurons. Everything kind of tends to bleed together a little bit when we knock down the P10. These cells also express a lot more of a marker called PTGR-Z1, which has been heavily associated with GBM development and is important in like radioglia formation. I'll mention that one to keep in mind when I talk about where I hope to go with this future and kind of my fellowship work and beyond, because I'll be translating this in kind of a different direction. And again, the just general organization of the organoids and the distribution of both neuronal and astrocytic cells is quite dramatically different than what we normally see in the wild types. Again, even just with the P10, and this gets exacerbated with the simple addition of fairly low levels of PTGF to the culture media. And then finally, one of the things we did just before I left was actually able to transplant some OR samples for human GBM tissue directly into these organoids and demonstrate their kind of engraftment, proliferation, and even invasion into the organoids themselves, which was more of a technical hurdle than I think either Dr. Patel or I anticipated in the beginning, but we were able to achieve some success with towards the end. So I'll finish with kind of where I hope to take this going forward. As Dr. Ellenbogen mentioned, I'll be pursuing a career in skull base and kind of steering away from the glioma work. And I think there's a recent paper from last year from out of UCSF demonstrating that we actually see a lot of this heterogeneity in higher grade meningiomas as well. This is kind of a busy slide, this figure from that paper, but suffice to say that the upshot of it is that there is a lot more heterogeneity and in particular increasing copy number variants and upregulation of like Wnt and other neurodevelopment signaling. I think actually these organoids might be a very interesting model for higher grade meningioma, and perhaps maybe a little more technically feasible given that these are obviously extraaxial tumors, and you could easily think of experiments, well, like, okay, if we take some grade 1 meningioma tissue, in theory, that might just sort of glom on and attach to the surface, but maybe with a grade 3, you would see more invasion. And could we kind of use something like, conditioned media from a higher grade to get a grade 1 to become more invasive and kind of recreate a transformation type experience and things like that. So that's kind of where I hope to take it in the future in the next few years. So with that, I'll kind of finish there and open it up to any questions.
Questions? I know, Mike, I didn't mean to steal your thunder. This is Mike's symposium to a degree. Mike, any thoughts, anything?
I think this is a really good example of a project that, started with one concept and sort of migrated into something that ended up a little bit different, but perhaps no less worthwhile. And the skills and the idea of cerebral organoids, I think, is applicable to a wide variety of fields. This is great work and a great job by Sam and Anoop.
Yeah, so questions, Anoop, can you tell us any insights into the great work that he's done?
Yeah, absolutely. So, as I said, the first thing I wanted to say is that, the generation of these organoids, Sam sort of trivialized the whole actual generation, the process of doing
a lot of work.
But it is an incredible amount of work. And yeah. I don't know if you saw some of the time scales that he was working on there, but sometimes, you know, to get the mature organoids that had all of the glia and everything, we were talking about 6 months of work to generate a cohort of these organoids. And just technique-wise, I can tell you, having tried some of this stuff myself, as well as talked to other folks who have tried this, it is non-trivial to get organoids that look as well patterned and as well made as the ones that Sam was able to get with just really a small amount of optimization of the protocol. So I think it really you know, is important to note that there is some technical skill here that Sam, you know, brought with him from his PhD work that really let him you know, jump on this and take this forward. But you know, I'm excited to see that you know, Sam is you know, still interested in working in the organoid system and you know, translating this into a, you know, a slightly different direction that dovetails well with, you know, his sort of future career clinical interests. And you know, I'm very excited to continue to work with him, mentor him in any way that I can, and see what he can do with this system, taking it forward and applying it in a different context.
Yeah, it's great, Sam. And let me add one more thing that Sam accomplished. Sam, you may not remember, if any of you saw the video we did on the UW neurosurgical program, which is being copied in many places, Sam added the drones. Sam brought the drones to us, the great drone photographs and video of the University of Washington. Sam, thank you for letting us use your military-grade drones for that project. All right, thank you. Without further ado, Maddie Greil, who is currently at Seattle Children's Hospital. Maddie was a young star at Johns Hopkins University, where she got her undergraduate degree in neurosciences. And then we recruited her from Case Western, where she was AOA and all kinds of great accolades. And she is going to speak about TBI. And Christine is her mentor, I believe. Is Christine on the? I don't see her. Christine, you want to say a word about what's going? Or no? Is this Randy? Maddie, which one is it? Who
yes, I'm working with Doctors Chestnut, Bono, and Temkin.
Okay, well, I was close because I picked on Christine. So who would like to speak on Maddie's behalf right now?
I can say a few words.
Thank you, Dr. Bono.
Yeah, so Maddie's done some very great preliminary work getting this project started. I think one of the holy grails in neurotrauma is you know, figuring out a way to monitor ICP without drilling a hole in somebody's head, or at the very least figuring out, you know, patients in whom you do need to drill a hole to get an accurate ICP. This is, I think, a very promising technology that we've been using here at Harborview a lot. There's some good data for it, but there's always room for more higher quality data, and that's what Maddie is trying to get for us. So I'll stop there and let her tell you about her project.
Good. Thank you. So I'm going to be talking about the project that I'm going to be doing for my research year starting in July. I'm looking at the use of the automated pupillometer, which we already use in the ICUs at Harborview in severe traumatic brain injury. So some background that you all know is we use invasive ICP monitors because they're the gold standard for measuring intracranial pressure, but there isn't great evidence on exactly when we should use them. Something that Dr. Chesnut and Dr. Temkin have been involved in was developing a clinical rule through a Delphi-based consensus process for some of their work in Latin America to kind of come up with an algorithm of when we should be more suspicious about intracranial hypertension in the absence of an ICP monitor. And some work that Aziz Alali did when he was Dr. Chesnut's fellow was to retrospectively validate this decision rule, but it has not yet been prospectively validated. And then, as you all know, the pupillary light reflex plays a critical role in the evaluation of TBI patients, and we have devices called pupillometers that look at the pupil size, how quickly it constricts and then dilates when exposed to light. And they have an algorithm that spits out the number, which is the NPI that the residents are commonly using at Harborview, which ranges from 0 to 5 with less than 3, indicating an abnormal response. Some prior papers have shown that there is a correlation between a lower NPI measurement and higher ICP, as well as seeing a trend for a decrease in NPI in the hours preceding an ICP spike in patients who have monitors in place. But I think there's a lot of room for studying this more. So my project has a couple aims. I'll spend the most time on aim 1, which is determining whether or not pupillometry can predict which patients will develop intracranial hypertension after a trauma. And our hypothesis is that this will show promising results. So we'll be looking at adult trauma patients at Harborview who are going to undergo ICP monitor placement. We will exclude anyone who has craniofacial or orbital trauma or edema that would prevent us from safely using the pupillometer in terms of the device being able to safely see the eye without causing any trouble. So the kind of biggest change that I'm trying to gather as far as data is getting a pupillometer reading just before placing the ICP monitor as kind of a metric. Could we use that initial reading to predict which patients would have ICP issues during their hospital stay? And then I'll collect kind of all the other clinical data on the patient, as well as looking at their head CTs. So based on some prior studies where the standard deviation for NPI had been seen and the number of patients that we typically see at Harborview and place ICP monitors in, we think that we can get, a reasonable power if we find a difference of about 0.5 in NPI. And then we also want to look and see if we can find an NPI cutoff that would have a good enough sensitivity and specificity to kind of help us in this predictive model. Because, 3 is kind of the cutoff that we use, but that hasn't been very well studied as to, how well that actually predicts anything. And then kind of my other aims, aim 2 would be looking at these patients when they're already admitted to the ICU with an ICP monitor and looking at the trends of NPI and ICP spikes. So looking in the hours before and after an ICP elevation to see if the NPI decreases in those, couple hours leading up to it. And then if it increases back to normal after we treat an elevation with something like mannitol or hypertonic saline. And then kind of on the other side of that, looking and seeing if when patients have a change in their NPI, if there actually was a change in their ICP, to see kind of what the sensitivity and specificity of an NPI change is for what might be more of a real clinical change. And then kind of going back to the crevice clinical rule, which is the one that Dr. Cheslin and Temkin had worked on in Latin America. I want to see if I can prospectively validate this because it hasn't been done before. So kind of looking at this group of patients, the major criteria are listed here and the minor criteria. So anyone who had one of the major or 2 of the minor were kind of in this high risk group for suspected intracranial hypertension. And then aim 4, seeing whether or not including pupillometry data would actually help to improve the accuracy of the prediction of this tool. So, adding in an abnormal NPI as either a major or a minor criteria, and then going through the process of evaluating the sensitivity, specificity, positive and negative predictive value in the tool, and seeing if that increases our ability to predict which patients will develop intracranial hypertension. So something that I'm excited about in this project is that I think that, if we succeed, it could have an impact on kind of treatment algorithms in multiple different settings. So Harborview is obviously, a very busy trauma center and, has a wealth of neurosurgeons available at all times. So patients that we're worried about can readily get an ICP monitor. But one thing that I think as residents, we sometimes struggle with is people that clinically we're not all that worried about based on, kind of their head CT or something like that, but they're just not giving us the exam that we would expect them to have, and whether or not we really do need to put a hole in their head in order to place an ICP monitor, and is there a way of predicting this better? And then in all of the hospitals that are transferring these patients to us, could they use something like a pupillometer, which doesn't need, you know, advanced training or a neurosurgeon to use to decide which patients, you know, need to be treated with mannitol or something before sending to us. And then in low and middle income countries where patients won't have access to an ICP monitor, could it help to identify patients who need to be kind of treated with expectant management under the assumption that they're very high risk and we wouldn't want them to kind of risk the consequences of having undetected intracranial hypertension that wasn't treated. And then I will open things up to questions.
Questions, anybody? Great, thank you very much, Maddie. Anybody questions? I think some of you actually need that pupilometer right now. Maddie, Malia, you're back. I thought you were. Are you going at the end? I'm sorry.
I can present now if you'd like, sir.
Oh, okay. Well, let me just finish with Rob, can you mention anything? Add anything?
No, I think, you know, Maddie's done a great job getting this project going. Looking forward to her getting her data collected over the starting in July, I guess. And it will be interesting to see what we find. I think this is a very promising study and a great start to it.
Great. All right. Malia, I thought was in the ER or was in the ER just till a little while ago when we just pulled her out of there. And so I'm a little unprepared, but I know Malia quite well in that she came to us from the MIT Harvard program medical school. And Malia, tell us a little bit. And by the way, I want to just say a comment about Sam and Ariana, and then Jake to follow. Our chief residents have published between 20 and 30 peer-reviewed papers. Malia's already off to a fast start. So Malia, tell us a little bit about who you're working for and what your project is.
Sure. So I'm just sort of starting the beginning of my research time, but I have just
the work you've done.
Yep. Oh, the work I've done previously was at MIT in Bob Langer's lab. I worked on coding devices, drug-embedded coatings for various medical devices, including catheters, antimicrobial, antithrombotic coatings specifically.
Great. Tell us what you're going to speak about now.
And today I'm going to speak about a case report that we recently, sorry, I'm just trying to pull it up here, that we recently submitted to Critical Care Medicine. I think I need access to.
Julie, does she have hostability?
Should have hostability.
Can you share your screen now?
Sure, I am.
Try.
Okay, now I can.
Yeah, go ahead, go, great, thank you.
Okay, so this is a case report that we recently submitted to Critical Care Medicine under Dr. Chestnut and Dr. Sarah Walster in the neurocritical care team.
Great.
So this is the manuscript that we submitted. It is a case report of a patient who had an unreactive pupil but maintained consciousness, and this was indicating acutely rising pressure in the setting of his traumatic brain injury. So the reason why we decided to publish this case report is basically we know that, of course, the central dogma is that any pupillary changes are something we follow very closely in the setting of these patients who we have concern for cerebral edema, but they are typically associated with a decline in consciousness. And that's why we feel that it's very unusual to have this unilaterally fixed pupil in this patient who is able to communicate and able to follow commands, but this is indicating a surgical emergency. So this patient is a 58-year-old man who presented after he was punched by his son and fell to the ground. He hit the back of his head and presented to Harborview. He had pupils that were equal and reactive 4 millimeters bilaterally. He had a GCS of 14. He was answering questions appropriately, just was a bit drowsy and had a left hemiparesis. This was his scan when he initially came in, which shows he had a right frontal bone fracture, bilateral contusions, including this right frontal interparenchymal hemorrhage. He had 4 millimeters of midline shift and some minimal subfalcine herniation. He was admitted to NCCS for Q1 neurochecks and contusion watch. And then on hospital day 4, his exam had declined. He had become more drowsy, but was still answering questions appropriately. And we got a repeat scan, which showed some blossoming of these contusions and worsening shift from 4 millimeters to 7 millimeters with right ankle herniation. At this time, we did give him hypertonics, and his pupils were reactive, and we felt that because his exam was still very good, we did not decide to do any intervention at the time. But shortly afterwards, on hospital day 8, suddenly his right pupil became dilated and minimally reactive. So his NPI went from 4.4 to 0.6, and his pupil diameter increased from 2 to 5. So his left pupil remained stable at that time, and the patient was still answering orienting questions, still following commands, and he was actually telling us that he was losing vision in his eye, or actually bilateral vision loss. And eventually his left pupil did start to dilate, and also his NPR started to decline on the left side as well. And then we got another scan, which showed continued worsening of his contusions, and we did decide to take him for a decompressive craniectomy on the right side at this time. And post-operatively, his NPI on the right side actually improved to 1.8. And by 24 hours post-operatively, his NPI became 4.1. We don't have a great anatomic explanation for why this patient was able to maintain consciousness, but at the same time lose his NPI on the right side. I think that just looking at his scan, he really has these large bifrontal contusions, and we're trying to think, well, what pathways are more anterior to the reticular activating system? Possibly it could be affecting his visual pathways much earlier than actually causing any downward herniation, and there's more subfalcine herniation. His cisterns remained pretty patent throughout this exam change. So our only anatomic explanation we can think of is maybe he's having more compression on his optic nerve at the time than actually affecting his reticular formation in his brainstem. So this is the discussion we had in the case report. And again, the reason why we really felt this was important for the critical care medicine community to understand is that in a patient who has these large contusions, we feel that even though they're following commands, if they have a pupillary change that is clear and declining, they should undergo a scan, and they should undergo just the process to rule out increased cerebral edema, and because they may ultimately require surgical intervention. And I'm happy to answer any further questions.
Great. Any questions? Anybody want to make a comment? I think, Rob, do you have any comments on what you think is going on?
Yeah, I think this is an interesting case that basically reminds us that we need to stay on our toes and not assume that what we know is, or what we traditionally think is always the right answer. You know, clearly this patient didn't have all the classic signs of herniation, but had some of them and needed surgery. So I think it's a great case report to just, again, remind us to think broadly and not jump to conclusions prematurely.
Great, Malia, thank you for presenting that, and we hope we find you a tissue engineer of your liking here. I know it's hard when you start with Bob Langer. So we will find you something to do in some engineering laboratory, I promise you, to keep a young lady who grew up locally. And it's great to have you back home, right?
I'm glad to be home, sir.
Yeah, that's all right. Jake, Ruzevick, one of my three great capitalist residents with Dr. Emerson and Dr. Barkley. I love when I get to sign checks for those three, which is like a weekly occurrence. Dr. Ruzevick grew up in the hood. He went to Coronado High School. If you've ever been to Coronado, California, that is truly la la land. He was a valedictorian of that high school, okay? And then he went off to a small engineering college in Massachusetts in Cambridge called MIT. And then he went to a relatively unknown medical school called Johns Hopkins, where he was the Doris Duke clinical fellow. He did a clinical fellowship. And as I said, our three chief residents, Jake has published 33 peer-reviewed papers, and he's going off to the University of Southern California for his skull-based fellowship. So we have both Sam going to the Brigham and Jake go to USC. Wonderful. So tell us a little bit about what you're going to talk about, Dr. Ruzevick.
Yeah, good morning, everyone. So this morning I will be talking about a clinical project that I worked on with Pascal, Sam, Dr. Patel, and Dr. Ferreira, analyzing our results of our posterior petrosal approach that has really been championed by Dr. Shaker. We had a series of 78 patients operated on at the University of Washington, and very happy to report that this is one of my very few clinical papers that had significant outcomes to it, and ones that I think are clinically relevant and hopefully will allow us to make clinical changes to improve the outcome of our patients undergoing these very large resections for tumors in very delicate places. So a little bit of background, our posterior petrosal approach, which other people, call the pre-sigmoid retrolabyrinthine approach. It's a hearing preservation surgery that allows us to get a slightly more lateral approach. Is certainly not new. It had really been optimized in the late 80s by Sam's future fellowship director, Dr. Al-Mefti. And it's certainly been well published, and I hope will be of interest to multiple people in our department, as many of the faculty have either been first author on or been part of multiple studies looking at the outcome of patients with petroclival and CP angle tumors operated on via this approach. I think what makes this study unique is that we look at outcomes of the specific approach, whereas the majority of studies previously look at the outcome of specific tumors within the CP angle. We have one of the largest series to date, and so I'm very happy to share those results. We performed a retrospective clinical series of adult patients age 18 or older undergoing a posterior petrosal approach between May 2015 and October 2020 at the University of Washington Medical Center. That encompassed 78 patients with 80 tumors. There were 2 patients with collision tumors, hence the greater number of tumors than patients. Our study population was predominantly female with an average age of 50. About 20% of patients had undergone previous surgery for tumor resection. The tumors were quite large, averaging about 17 cubic centimeters, and about a third of patients had undergone pre-op embolization, showing how, how common it is, mostly for meningiomas. The primary pathologies are what you would expect. The most common pathologies are in the CP angle are schwannomas, meningiomas, and epidermoid cysts, and those 3 entities constituted over 80% of the pathologies that were resected. When we looked at our surgical outcomes, not unexpectedly, they were long cases. The estimated blood loss was about 300 cc's. Just over half of the patients received a gross total resection. And I think interestingly, the rate of postoperative sinus thrombosis, which is not often discussed, was about 14%. I'll get into that more when we look specifically at the different pathologies. The length of ICU stay was about 3 days, and overall length of hospitalization about a week. Interestingly, there was a pretty high CSF leak rate at 15%, and I'll go into that more in the later slides. About 17% of patients required readmission within 30 days. The overwhelming majority of those were for CSF leak with delayed hydrocephalus. And ultimately, the majority of patients were able to discharge home. I think some of the interesting data is shown here on these next couple slides, where we look specifically at schwannomas, meningiomas, and epidermoid cysts. I show the tumor volume to show that these are all pretty giant tumors, and show that ultimately surgery for epidermoid cyst was associated with shorter operative times compared to schwannoma or meningioma. The rate of postoperative sinus thrombosis was also much lower for epidermoid cyst. It was the highest for meningioma, and there is previous literature to suggest that venous thromboembolism is common and is more common in meningioma, and so I'll dive into that more a little later. The length of ICU stay was shorter for patients undergoing resection of epidermoid cysts, as was the overall length of hospitalization. Ultimately, the CSF leak rate was much higher in patients with epidermoid cysts. They constituted a majority of the reasons for delayed readmission, and the need for permanent CSF diversion via VP shunt was also much higher in those patients with epidermoid cysts as compared to the other pathologies. So based on this analysis, we found that surgery for epidermoid cysts were associated with shorter length of surgery, ICU stay, and overall length of hospitalization, as well as a trend towards increased rates of CSF leak and need for permanent CSF diversion. We also found that meningiomas are associated with higher rates of sinus thrombosis. We performed a multivariate analysis to look at predictors of multiple surgical outcomes, and those are shown across the top. We used age, sex, history of previous surgery, history of previous radiation, tumor volume, pre-op embolization, and tumor pathology as potential predictors of these outcomes. And we found that tumor volume and pathology were statistically significant predictors of both length of surgery and overall length of hospitalization. When we combined all these results, the pathology had dropped off as a statistically significant predictor of CSF leak, though there was a trend with a p-value of 0.07. I think importantly, we then showed cranial nerve function after a petrosal approach, and I think this is especially relevant to all the residents on the call who don't typically follow these patients from longer than their inpatient stay and maybe immediate postoperative visit. So I think the thing to take away is that cranial neuropathies are very common after a posterior petrosal approach, with upwards of almost 50% of patients experiencing cranial nerve 7 palsy, and about a third of patients having cranial nerve 5 palsy and cranial nerve 6 palsy. However, when you follow these patients out to 1 year, you see that the actual incidence of a new cranial neuropathy that persists at the 1 year follow-up is actually quite low. So the overwhelming majority of these neuropathies will recover. And really the key is to keep the nerve in continuity. We have multiple mechanisms of monitoring that. And so that's really the key in making sure that even if there is a palsy postoperatively, the chances are it's going to get better. So our significant findings from this study is that we found that surgery for epidermoid cysts are associated with shorter length of surgery, ICU stay, and overall length of hospitalization. However, they frequently represented through the emergency room with delayed hydrocephalus and need for shunting. So I would propose closer post-hospital evaluations for hydrocephalus in patients undergoing resection of epidermoid cysts, whether that's an early CT or even potentially an LP if there is any concern for dilating ventricles or pseudomeningocele that seems to be worse than what one would clinically expect. The second finding was that postoperative cranial neuropathies are quite common, especially cranial nerves 5, 6, and 7, but most will resolve by 1 year follow-up. So potential clinical changes would include focus on postoperative care to prevent any associated morbidities with these cranial neuropathies, including lubricating the eye or keeping the eye shut at night. And then finally, postoperative sinus thrombosis and venous thromboembolism, which I didn't show in this talk, are actually quite common in surgery for meningioma. and that delayed hydrocephalus occurred in 18% of patients with sinus thrombosis. So, you know, we treated the majority of these patients with aspirin, but there still was some morbidity associated with the sinus thrombosis as a potential cause for hydrocephalus. And so I'd propose consider starting prophylactic aspirin or immediate initiation of, you know, sub-Q heparin or Lovenox immediately postoperatively instead of waiting a typical 24 or 48 hours. And with that, I'll take any questions.
One of my first questions that I had, I thought that was fascinating about the epidermoids and then the thrombosis of the sinuses with the meningioma. How about ventricking all these patients or lumbar draining them? Perhaps you can get rid of the delayed hydrocephalus. You know, certainly with epidermoids, it must be the sort of material that sheds in the CSF that causes that obstruction. Any thoughts about that, Jake?
Yeah, I think that's certainly a very plausible and I think likely mechanism for the, you know, more of a chemical meningitis causing delayed intracranial pressure as opposed to a obstructive type hydrocephalus. You will see we did study the use of EVD in all the patients. They were present in 80% of, or they were used in 80% of patients. We did not find any correlation between any ICP measurements in the ICU that predicted any postoperative hydrocephalus.
Okay, that is wonderful. Any other questions? Questions from the audience, please.
Jake, I'm just curious, did everyone get a MRV or CTV? I mean, do you think you missed a fair number of sinus thromboses, or do you think you found them all?
I think we missed quite a few of them. CTA was not regularly employed as a, you know, normal postoperative scan until the last few years. So I think there are multiple patients that we likely missed a sinus thrombosis in.
All right. Anybody else? Dr. Patel, you were on that paper. Anything you want to add? Okay, he may not be alive. All right, let's move on to Dr. Rajeev Sen. Are you ready, Dr. Sen?
Yes, sir, ready.
All right, so Rajeev Sen went to one of the finest undergraduate schools in the country, Columbia University, where he got a classical general liberal arts education, despite the fact that he got his degree in biophysics. And then he went off, he wandered about 2 miles away to New York University School of Medicine, inveterate New Yorker. I should mention, while he was at Columbia, he worked in none other than Eric Kendall's, the Nobel laureate's lab, and Larry Abbott's laboratory. He went to NYU, and somehow we extracted him out of New York City, and he came to the University of Washington. So, and we're thrilled about that. So tell us a little bit what you're talking about, Rajeev.
Great, thanks, Dr. Ellenbogen. So I'm gonna talk a little bit about kind of an offshoot from the project I'd presented at our last symposium on timing of AVM, of ruptured AVM resection.
Great. And you're going to tell us who you did this with?
And yeah, this is with Dr. Shaker and the cerebrovascular group and your patients. It includes your patients as well.
Yep. Thank you.
That work? Okay. So the title of this project, clinical project, is Concurrent Decompression and Resection of Acutely Ruptured Brain Arteriovenous Malformations. Just a little background. So I think most of us know that the most common presentation of AVMs is intracranial hemorrhage. About 50% of cases present as such. And the in rare cases, the hemorrhage is severe enough, the intraparenchymal hemorrhage is severe enough that it requires surgical intervention emergently. So the surgeon is presented with two options at that point: is a decompression alone, followed by management of the AVM later on, versus concurrent decompression and evacuation of clot, as well as resection of the AVM. The re-rupture rates of AVMs in the acute setting are much lower than that of aneurysms. So the general thought is that you do have some time to wait, on the order of weeks, and that's safe. So our question was, does concurrent decompression and resection in this case impact length of stay or clinical outcomes? And our initial hypothesis was that concurrent decompression resection may reduce your length of stay and potentially lead to better clinical outcomes. So we did a retrospective study of our cohort dating back to 2005. So this flow sheet kind of details our patient population. So starting off with about 270 AVMs that underwent resection. We took out all the unruptured ones and those without an intraparenchymal component to their hemorrhage. And obviously a majority of these patients were relatively stable on presentation, so did not need any emergency surgery, but ultimately ended up with 35 patients that required emergent surgical intervention. Stratified those into two groups. So we had 18 patients in the group that had concurrent decompression and resection. We called those the hyperacute patients, and then 17 patients who had a decompression alone and then delayed resection of their AVM. And our primary outcomes were length of stay and ICU length of stay, and then we had several secondary outcomes related to degree of resection and clinical outcomes. So this table just details our baseline characteristics for the two groups. Just pointing out some specific lines here. So the GCS upon presentation was similar between the two groups, but there was a little bit more dispersion in the data for the hyperacute group. So a larger proportion of them had a GCS of 3, so pretty devastating neurological exam. The RAGS and AVICH, these are two fairly novel grading systems for ruptured AVMs that it's kind of analogous to the Hunt test score for aneurysms, just basically predictors of mortality, and those were similar between the two groups. Pointing out time to resection, so obviously for the hyperacute group, that's going to be close to 0. And then for the delayed group, in our population, resection was usually within or around 10 days after rupture. There are people that wait even longer than that, up to 4 weeks. So just interesting point about our practices. And then down towards the bottom, clearly kind of maybe a obvious difference would be in the number of endovascular treatments or embolizations. So the hyperacute group did not have, had significantly fewer embolizations than the delayed group, usually because they had a resection almost immediately from their presentation. And those are the main differences there. And then after our multivariate analysis, comparing the two groups, we, for length of stay and ICU length of stay, did not find any significant difference between the two. For our secondary outcomes, we did find that the immediate functional outcomes by MRS were better for the hyperacute group who underwent resection, decompression and resection, but this didn't really carry forward into our long-term outcomes. And also hospital complications related to hospital stay were similar between the two groups. We also did a somewhat of a qualitative analysis to finish off the project. So we went through the operative reports for each of these cases and tried to identify any patterns of challenges in surgery or complications. And here on the left is the hyperacute group, on the right is the delayed group. But basically, to summarize this table, we did find that there was a lot more comment in the hyperacute group for severe intraoperative hemorrhage or of the AVM. So about nearly half of the patients in the operative reports, the surgeon comments on uncontrollable or difficult to control bleeding. Didn't really find that in any of the cases in the delayed group. It seems like by reading the notes that it was most commonly due to premature breach of the nidus or deep arterial feeders. And then we also just kind of stratified the patients into surgeons who had less than 10 years experience and more than 10 years. And we did find that in the hyperacute group, in these cases with the severe hemorrhage, these surgeons were on the less experienced end of the spectrum. So what we concluded from the study is that concurrent decompression and resection of these acutely ruptured brain AVMs is possible, and you don't compromise length of stay or long-term functional outcomes, but surgery in that setting may lead to a more challenging resection given the more hostile operative environment, more swelling, and without kind of complete imaging with angiograms, may be more difficult to localize the draining veins and feeding arteries, and should really be spared for select patients in the right setting.
So let me, very superb. Can I ask Dr. Levitt, who's been amazingly quiet throughout this whole thing, to give us a little perspective? And I know Sheikh was involved in this work intimately, but first you, Mike.
Yeah, I think this is a good use of a clinical retrospective data to try and tease apart some practice differences and see if there is a difference. It's still subject to the same, recall bias and selection bias, but I think that this is a difference in approach of these patients. AVMs are not like aneurysms, so the need for, acute within 24-hour resection is debated. And I think what this shows is that either solution will work. There's not necessarily a better solution, one versus the other. And so it's a per patient basis. I generally avoid hyperacute AVM resection at the same time as decompression because it's just harder. You don't have the angiographic information and you don't have the benefit of embolization. But for simple or superficial AVMs, it's certainly fine. And I don't think what this study shows is doesn't look like there's a problem either way. So this is a good addition to the literature just to kind of discuss this controversy.
Shaker?
I think the motivation or incentive for the study was really the adage that exists in all the textbooks that AVM surgery should be delayed for a long, long time. So that was always the teaching in my time. So people with AVMs were never operated early. They were usually, we were usually told that you should wait at least 4 to 6 weeks until the clot resolves, et cetera. So when I came here, I had adopted an early policy to operate on AVMs quite early, but based on CTA. What that means is that if the CTA shows that it is a resectable AVM, according to the surgeon's judgment, I would do them, quite early. Obviously, the patients who are simply decompressed so that those in whom we don't have adequate information, or people in whom the AVM looks to be pretty bad, requiring embolization. So the initial motivation was to show that early surgery, see, if you notice that both of these groups that he has presented are kind of early surgery, not really delayed surgery. We don't have a corresponding cohort of delayed surgery. Most of the people operate here are operate relatively early, whether it's hyperacute or acute. I would step back for a minute and say that both of these have very good outcomes in general. And how do you, perhaps one can say that, how do you choose to do the surgery hyperacute? Maybe that should be distilled from the paper. And I think that's purely based on what Mike said just now. that is based on the surgeon's judgment and the CTA, then you can remove the AVM early. The only downside of that, I don't know if it came through in this presentation, is that sometimes you may end up leaving residual AVM, which then goes on to reresection or gamma knife radiosurgery. Also, those are the patients who do not require more than one embolization procedure. So I think that it is, in talking to AVM surgeons around the country, I noticed that some of the others have evolved in the same direction. Nobody yet has publicized this information. So I think that that's, I don't know what's happening with Mike Lawton at Barrow, but I know that Dr. Heroes and Jack Marcos still sticking to the old practice of waiting and waiting. And I think waiting and waiting just loads up our ICU stays, increases complications, and keeps the patient out of work as long as they can. I just don't think that's necessary anymore. So we can, get on with these people. It's not, don't need to treat them acutely as we do in aneurysm surgery, but the earlier the better.
Thank you. Nice, hopefully great contribution. Challenge to conventional wisdom, as I put that under. All right, great. Thank you, Rajeev. And vascular group. Sananthan Sivakanthan. So Sananthan, I think you're presenting your R25 work. For those that don't know, Sananthan, he went to he grew up near Pittsburgh, went to University of Pittsburgh and got a bachelor's of science degree, then went on to the University of South Florida in beautiful Tampa, Florida, where he got his medical degree. And he won I didn't realize this, I forgot that you won the Stephen Spector Outstanding Contributions to Scholarly Achievement and Advancement of Medicine in your graduating class. So you won a research award in your graduating class at the University of South Florida, went off to New Mexico, and then transferred to the University of Washington when that program disappeared. And R25 funded research to come with Dr. Hofstetter. Is Christoph on? Significance of this? Is Christoph with us?
Yes, I'm here. Thank you so much for letting Sananthan present his work. So the significance of this is that Dr. Papadopoulos in Great Britain has been shown that after spinal cord injury, roughly 2/3 of patients have intraspinal pressure increases. So very much similar to trauma in the spine. And can you still hear me? Can you hear me still?
Yes, we can hear you.
Sorry, I just got a call. And so, as we have seen before, direct pressure measurements with a pressure probe, similar to intracranial pressures, have not, really sort of held up the promise in patient outcomes and management. And so, one thing that we have been doing in a translational program that we have developed in rats, pigs, and patients, we have developed contrast-enhanced ultrasound. So what Sananthan is now doing is elevating our previous work by adding absolute values to that. So basically, the nice thing about the work that he's proposing is that elastography will allow us to determine the elastic modulus of tissue, which is an absolute number, and hopefully is going to be a better biomarker to see what patients would benefit from durotomy in the case of acute spinal cord injury. And again, there's currently a multi-center trial in Great Britain going on, and I hope that this technique is going to help us to elevate a similar trial in the US to a more sort of standardized pace.
Thanks, Christoph. Appreciate it. And Sananthan, you ready to go?
Absolutely.
Thanks.
Thank you, Dr. Hofstetter, and thank you for both the professional and personal mentorship you've given over the past 2 years that I've been here. I'd also be remiss if I didn't thank Dr. Zin Kang, who I know is on the call, Dr. Matt Bruce, and Dr. Sharon Durfee for all their help in getting this together. Without them, this would not have been funded. And then finally, both Dr. Zellenbogen and Dr. Zojman for giving me this opportunity and for all their help and mentorship throughout this process. What really drove me to spine over the past few years is just the high impact of the pathology. Spinal ailments are the top 5 most common complaints that anyone comes to a physician with, and that includes spinal cord injury. Spinal cord injury in the U.S. Has the highest prevalence of any country, with an estimated incidence of 906 cases per million inhabitants. And spinal cord injury results in approximately $19 billion of direct medical care expenses annually. That's not to account for all the indirect medical care expenses that it results in. And despite this profound impact on public health, there are actually very few guidelines on exactly how to manage spinal cord injury. So the purpose of this study is to start a translational project that will hopefully answer these questions. And to do this, the tool that we're utilizing is the ultrasound, and specifically an ultrasonic technique called shear wave elastography, which is a quantitative estimate of the elastic and viscous properties of a tissue. And I can't emphasize the word quantitative enough. Typically, when we do an ultrasonography, we have these really beautiful maps of the tissue density, but this technique allows us to have an absolute value, as Dr. Hofstadter said. The shear waves are generated and tracked in the tissue with the ultrasound, and the speed at which the shear wave travels is directly linked to tissue stiffness. So that's what we're measuring, and from that speed, we can derive an elastic modulus, which is a measurement of the stiffness. In spinal cord injury in general, a high energy trauma results in disruption of the blood vessels and subsequent hemorrhage and vasogenic edema. This results in a spinal compartment syndrome, the so-called spinal compartment syndrome, which is akin to a compartment syndrome in an extremity, or the Monroe-Kelly doctrine in cranial trauma. On the right, you see traditional ultrasonic images with the contusion outlined in both B mode and SWE image formats. The project that we proposed has 3 arms. The first arm is to determine the pressure dependent elastic modulus using ultrasonic elastography, and this will be broken up into 2 parts. The first part is homogeneous phantoms of known elastic moduli will be molded to a geometry similar to the rodent spinal cord and used to validate velocity estimates. And in the second part of this first aim, we'll take rats and place gel foam pieces within the epidural space of rats and use tissue elasticity changes as compared to pressure probe measurements of intraspinal pressure to validate elastography as a pressure monitor. In the second aim, we'll utilize the elastic modulus to determine the interspinal pressures in response to injury. We'll have 3 groups of rodents, which will be exposed to varying degrees of injury, first mild, moderate, and severe, all through a standardized infinite horizon impact device that creates the thoracic contusions. We'll then perform invasive intraspinal pressure measurements by using a pressure probe directly in the spinal cord parenchyma and compare that to ultrasonic imaging analysis to assess both perfusion and elastrometry. And then finally, we'll measure the change in the elastic modulus and intraspinal pressure after decompression. Following the ultrasonic studies, half the rodents will be randomly selected to undergo durotomy. And after durotomy, they'll be subjected to repeat ultrasonographic assessment to determine the impact of that durotomy. So this is really trying to set up a translation to the human model where we could predict patients who would potentially improve with durotomy and surgical intervention in spinal cord injury. In addition to the quantitative measurements with the ultrasound, we'll also supplement this data with behavioral testing using 2 standardized rat behavioral test the BBB and the catwalk analysis. That's all I had. Again, this project was funded by the R25, and hopefully next year I'll have results to present to you guys. I'm happy to entertain any questions.
Sananthan, excellent. Congratulations on your R25.
Thanks, sir.
I didn't realize you won a research award in medical school. Congratulations for that. Any questions? Christoph, you want to say a word about the importance of this work, perhaps?
You know, I think the biggest challenge here, the biggest opportunity is to use sound waves to better delineate tissue. And obviously another opportunity here is, and Per would sort of chime in on that, is that this really opens the door for non-invasive monitoring at some point because these piezo elements are on an economic scale very affordable. And so I think it really, this will path the way for sort of some enhanced tissue health perfusion monitoring that, you know, down the line for postoperative patients and other ailments.
Dr. We have Dr. Moreau. You have a question?
Yes, sir. Comment. Excellent work, of course. It's worth noting, Christoph, I have a clinical system that perhaps we could use on patients. It is FDA approved that does this measurement. I don't know if you're using a Verisonics or another kind of system, but that exists. And yes, it's time to put that monitor together that we discussed a few years ago.
Per, that's a great, I'll call you later today because, you know, I've had the great opportunity to now do more clinical work and I'm super excited about this. So I'll call you later today. Thank you.
Good. A collaboration born from this conference. I love it. I know you.
Absolutely.
All right, without further ado, let's go to John Ross Williams, or as I call him, John R. Williams. John has had a very colorful past, might I say. He went to undergraduate school at Swarthmore, where he majored, I bet none of you will get this right, but he majored in film and media theory. And he then was awarded, earned a Fulbright scholarship and went to Humboldt University in Berlin. And hey, John, has that ever been published, that paper you did that was great? I know that with the Turkish students and all that. Has that ever been published?
Not in an academic journal.
For crying out loud, that's got to be added to your repertoire. It was such a great idea, such a good thought process. Anyway, and he also minored in lacrosse, where he hit other men on the head with sticks. And he is now, of course, he went to Brown University, Warren Alpert Medical School, where he excelled, and we recruited him to here. John, tell us a little bit about what you're going to do and talk about.
Absolutely. So I'm actually going to present a paper that was published in the last year with a couple folks outside of the department. It's a little departure from my main funded research, but I think it's just a very interesting paper and a nice way to introduce a current MS4 here at the University of Washington who will be applying into neurosurgery and actually rotating with us in the next couple of weeks. But just the headline of the paper. So it was published in JAMA Open Network, and it's titled Trends in Race and Ethnicity Among Applicants and Matriculants to U.S. Surgical Specialties from 2010 to 2018. The lead author there, Edwin Nieblas-Bedolla, is who I wanted to introduce and thank at the same time. As I said, Edwin's currently MS4. He'll be rotating with us at the end of the month, doing his first sub-I. He has an incredibly interesting backstory that I'll let him tell on the fly when he gets to meet all of us. But he has a medical student here, MPH from University of Pennsylvania. And since he emailed me at some point in my research year, he has been one of the most diligent, productive medical students I've ever encountered.
And delightful guy.
Yeah, and just wonderful to work with. In general, 5 years ahead of anything I was able to do as a medical student. And I have a short list of some of the things that he has actually published in the last year. The bolded ones are ones where he was first author, but he's just been really wonderful to work with and just incredibly intelligent in terms of thinking up great ideas and seeing them through at a very rapid pace. So in any case, back to this study that we worked on together, it was a pretty straightforward survey. So we were examining trends in the percentage of applicants and matriculants to US surgical specialties who identified as part of a racial or ethnic group that is underrepresented in medicine. From 2010 to 2018, all racial and ethnic identities were self-reported. And the groups that we included in our definition of underrepresented minority included Black or African American, American Indian or Native, Alaskan, Native Hawaiian or Pacific Islander, and Hispanic or Latino. It was a cross-sectional study. All of our data was acquired by Edwin from the Association of American Medical Colleges, and again, the timeline was 2010 to 18. The surgical specialties that we looked at specifically were categorical general surgery, neurosurg, OBGYN, ortho, oto, plastics, both thoracic and vascular integrated, surgical residencies in urology. Chi-square tests were used to assess changes in proportions across all years and individual races and ethnicities. Results were significant. Two-tailed t-test showed a p-value less than 0.5, and then we followed the stroke guidelines. Overall, so through that time period, there were 130,000 applicants, 40,000 matriculants into those 8 specialties. Of those, over 21,000 applicants and 5,700 matriculants self-identified as underrepresented. And then throughout that time period, the overall percentage of both applicants and matriculants that identified as underrepresented, there was no statistically significant change. So in 2010, 15.3 in total applicants identified as underrepresented, and in 2010, 17.5%. So there was an absolute increase, but it was not a significant increase. This is just a flow chart showing the breakdown of surgical, non-surgical applicants, and those of which identified as underrepresented. Thoracic surgery was the only subspecialty within this group that did have a significant change in both the percentage of applicants who identified as underrepresented and percentage of matriculants who identified as underrepresented. However, the thoracic surgery as a categorical subspecialty is a relatively new thing, and they had the lowest proportion of underrepresented applicants and matriculants in 2010. So basically, these numbers were driven by very low N, so to speak. So there were fewer than 20 total positions available in 2010 that grew a bit, and just a handful of more applicants and matriculants was able to drive a significant finding. OBGYN had the highest mean percentage of underrepresented applicants and matriculants across this entire time period. Thoracic surgery had the lowest mean percentage of applicants, and oto had the lowest mean percentage of matriculants over that time period. Just to highlight how neurosurgery fell in, you can see that applicants went up about 2 percentage points from 2010 to 18. Matriculants, the same. There was very little difference in the percentage of applicants versus matriculants over that time period. But again, like all other specialties aside from thoracic surgery, we did not have any significant change in either applicants or matriculants over that time period as a whole. And then thoracic surgery is highlighted here, and you can see that they did have a significant change, but their numbers were kind of all over the place just because that field is actually tiny. Bird's eye view. This is just a breakdown of all surgical applicants, matriculants over this time period, broken down by racial composition. So you can see the tall bar there are white matriculants, the smaller green bar are Asian, and then the very small bars are the groups that are identified as underrepresented. And if you just kind of look across this figure here, you can see that it looks like we copy pasted the same graph year after year. So there are minor changes, but overall it was basically static in terms of the racial breakdown of surgical matriculants in those 8 specialties. So to kind of get back to what underrepresentation is, that term, so our definition really came from the National Science Foundation, who started to identify these trends in both the medical fields and the STEM fields. But these racial and ethnic groups make up 28 to 30% of the US population. But if you look at our study here, only about 16% of applicants and 14% of matriculants are from those same racial and ethnic groups. So that's the underrepresentation. They're a certain percentage of the population, but they're only representing about half or less of the population of surgeons in training out there. Our data seems to mirror prior studies over a similar time period in radiology, dermatology, and emergency medicine. So this trend seems to be happening across multiple fields. And then the other kind of disappointing finding is that this runs counter to some studies that had come out prior to 2010 that were actually showing increases in the numbers of underrepresented minorities who are applying to and matriculating in surgical subspecialties. So there was some effort that improved representation, but this plateaued, it seems, starting around 2010. If you take a broader view, it actually turns out that this is probably related to underrepresentation at all levels in medicine. So it's not just the number of medical students who are choosing to apply and able to matriculate into surgical specialties. It turns out that those folks are underrepresented from the start. So medical school applicants, matriculants, and graduates are all underrepresented proportionally. And then this is mirrored throughout the residency application and training process, and only 12.8% of practicing surgeons in the US identified as underrepresented in 2018. I guess somewhat good news, depending on how you frame it, there are a higher proportion of underrepresented applicants and matriculants into surgical subspecialties compared to non-surgical specialties. So surgery seems to be attracting a better proportion of the underrepresented population. And then across all specialties aside from OBGYN, there was an absolute increase in the proportion of applicants and matriculants who identified as underrepresented from 2010 to 18. This is just a graph that shows surgical applicants, non-surgical applicants, and then surgical, non-surgical matriculants over that time period. And just by the proportion of those applicants and matriculants who are underrepresented. And again, this emphasizes my prior point that there are a higher percentage of underrepresented minorities applying into surgery, as you can see by these gray triangles compared to these blue squares, which are non-surgical applicants. And then a higher proportion of surgical matriculants compared to non-surgical matriculants. However, you can see, at least with the applicants, that gap is closing. So we've identified a trend and a problem. What can we do about it? So just taking a look at prior literature, there have been studies that have shown that direct exposure and longitudinal relationship building have been successful frameworks for providing resources for applicants and trainees who identify as underrepresented to advance through this entire course, which we know is very long and arduous. There are two programs. One is called the Diverse Surgeons Initiative, and the other is the Harold Amos Medical Faculty Development Program at Robert Wood Johnson Foundation. Both of those have published a number of studies that have shown basically provided a framework for relationship building and longitudinal mentorship that have helped increase numbers of underrepresented folks involved with those programs that are going into surgical fields and actually making it through training and into academic positions. There's also evidence that early exposure to surgical specialties through strategic support, like summer internship programs, may help basically introduce people to these fields, make them seem more real, more achievable, not just something abstract that you see on TV. And they've been associated with significant increases in applicants who identify as underrepresented. I have a little picture here from our neurosurgical student summer program. You can see Dr. Ellenbogen with some of the folks who have come through here to try and help with this introduction and relationship building. And then we encountered and described a little bit about an interesting paper that came from, it was in the Annals of Surgery. It came from author Cochran that describes the grounded theory model of successful mentorship. But basically the big finding from this was that a lot of development programs have focused on hiring faculty from underrepresented backgrounds and then have placed an undue burden on those faculty, and this is both racial. Seems to hold true in studies on racial and ethnic representation as well as gender representation. But basically, if you emphasize too much on faculty mentorship, you have a smaller number of faculty who are burdened with a much higher demand on mentorship and minority leadership, and so they kind of explored different models of mentorship that are effective, including a broad range of mentee and mentor backgrounds that are very diverse. So basically emphasizing the need for folks who are not from underrepresented backgrounds to take on a mentorship role as well, while acknowledging that there's there are differences between the mentee and mentor, and that there's been an over-reliance on a fixed mentorship diet. And then just thanks to everybody else who was on this paper. So not only Edwin, but Brianna Christophers, who's an MD PhD student at Cornell, who's worked with us on a couple papers and is wonderful and brilliant as well. And then Chris Cohen, who's a ortho resident here. Dr. Williams is an attending general surgeon here at the UW. And then Dr. Jimenez, who's an attending anesthesiologist at Seattle Children's. And that's what I have.
That's great. And John, one thing, although it's not the classical teaching, there's only 6% now, up from 5% board certified neurological surgeons that are have 2X chromosomes, women. And I'm proud to say that we got our top 3 choices for residents, and under that classification, all 3 fit URM. So women in neurological surgery are URM, not in other surgical subspecialties, because they've been better about getting women involved. And of course, we got our top 3 choices this year, and all 3 fit in that category. So great paper. Thank you. Edwin is doing, we look forward to Edwin rotating on our service. And John, that paper is out already in PDF form, correct?
It is, yep. It's out there.
Send me your recent copy. Thank you.
Sure.
All right. Without further ado, our last speaker, okay, is none other than Christopher C. Young, MD, PhD. Chris comes from a beautiful place at the University of Cape Town in South Africa, where he got his medical degree with first-class honors. Prior to that, he was awarded a Rhodes Scholar. One time we had both he and Peter Chiarelli in our program. Now we have just Christopher Young, who went to the University of Oxford and got his Doctor of Philosophy and Physiology, studying adult stem cells. And he has been extremely productive, a good writer, published over 24 peer-reviewed papers. So not least, but last, Christopher, tell us about some of the things you're doing at SANS with a group. You have both both leaders of SANS here. And Dr. Levitt, you want to give us some insights into some of the work he's doing at SANS?
Sure, I don't want to take too much time up, but suffice to say, he's really been focused on endothelial cells and their the mutations or changes that we can observe in those that lead to cerebrovascular disease, especially a more novel method of minimally invasive way of biopsying or obtaining these cells for analysis.
Great, thanks. Chris?
Hey, thanks, Dr. Elmo, and thanks, Dr. Levitt, for the introduction. I want to talk about my project looking at the molecular basis of endothelial dysfunction, and with that to try hopefully come up with a way to personalize some risk stratification in the management of cerebral aneurysms. So cerebral aneurysm rupture causes significant morbidity and mortality, and there are increasingly diverse strategies to treat aneurysms, although there are, of course, risks and costs involved with some treatment. So as such, we have natural history studies such as ISUIA and UCAS, which tell us that small aneurysms less than 7 millimeters can be watched and managed conservatively. We also have meta-analysis from 6 natural history studies that have led to the phases of aneurysm risk score, which is a composite of known risk factors for us to inform clinical decision-making. Yet, the majority of patients that we see with some acute subarachnoid hemorrhage and ruptured aneurysms, they have small aneurysms. They don't have large aneurysms. And so I think in reality, we don't have a perfect predictor of which aneurysms should be treated immediately and which are the ones that we can safely observe. I think this speaks to the fact that not all aneurysms are the same. When we image an aneurysm at one point in time, it is difficult to predict the risk of aneurysm rupture. And work done in our lab by Dr. Kim and Dr. Levitt have focused on how hemodynamic stress may influence aneurysm formation. And this is a figure from a paper a couple of years back, and how using computational fluid dynamics, we have started to look at these flow-related forces. And this figure demonstrates one of these concepts, the idea of wall shear stress. And here you can see in the parent vessel near the neck of the aneurysm is associated with high wall shear stress, whereas in the dome of the aneurysm, the flow is different, has low wall shear stress. So, we thought that, surely at a cellular level, there is likely a functional aspect to the factors which govern aneurysm growth and rupture. So our hypothesis is that there's a genetic signature of high-risk aneurysm, and that this genetic signature may reside in the endothelial cells which line the luminal surface of aneurysms. And to get at this question, we optimized a novel technique to harvest endothelial cells from aneurysms in patients undergoing endovascular coiling. These endothelial cells are collected for next generation single-cell RNA sequencing, and then the data we obtain can be interrogated and analyzed using bioinformatic approaches, and thus to identify genetic signatures of risk. During aneurysm coiling, occasionally the coil is not deployed and is taken out. And what we did was we collected these undeployed coils and processed them to strip the cells they may have become adherent to them. So here is an example of the cells that we've taken off the coils. You can see there's a lot of cells here, although only a very small percentage of these cells are actually endothelial cells. So in order to isolate the endothelial cells, we use fluorescent activated cell sorting and process the cells that we strip, so that we label them by CD31. These are surface markers. CD31 is PCAM, and CD4 positive and then CD45 negative cells, CD45 being a leukocyte surface marker. And in doing so, giving us the pure endothelial cell population. Once we have these cells sorted and each cell in its own container, we use the Smart-Seq technique. This is a technique Dr. Anu Patel had helped pioneer, in glioblastoma. And we use this technique to extract the RNA from each individual endothelial cell and use that RNA and amplify that into cDNA. And then from there, construct a cDNA library from which sequencing can take place. And what I show here is a quality control from a tape station of the amplified cDNA. And you can see, this is a representation of the different band size fragments that inform us that the cDNA is of adequate quality from which our molecular material have been obtained. So, just to sum up on where we are, my project is about searching for a genetic signature of high-risk aneurysms. And thus far, we have demonstrated that endovascular endothelial cell collection from patients during treatment coiling is safe and feasible. We've collected cells from about 20 patients, and these are stored away. We've also been able to update our IRB so that going forward, we are able to collect coils and cells from a lot more patients than we have been able in the past. We have our fluorescent activated cell sorting technique, and that gives us some single CD31 positive, CD45 negative endothelial cells from the cells that we strip from the coils. And at the moment, we are working with the molecular biology to prepare the cDNA library for sequencing. Concomitantly, what we have also done during this period is we have collected about 20 aneurysm domes from open surgery. These are clipping cases by Dr. Kim, Dr. Levitt, Dr. Shaker. And what we plan to do is to also perform single cell RNA sequencing on these tissue, and this will be used as a comparative control. So, for me personally, this has been an enormously exciting project, and I hope to continue working on it, going forward. We have a couple of residents going to research that is going to also work along this project. So I think, we're going to have some interesting data coming out. And in closing there, I just want to thank, Dr. Kim, Dr. Levitt, Dr. Ellenbogen for their tremendous support that made this work possible. And I want to highlight the role of Sam Levy. He's one of our post-bac scientists in SANS, who's heading off to do a PhD. Not sure exactly where he's going, maybe Hopkins or San Diego. He has really, helped tremendously in this work during the past 18 months.
Great, Chris, thank you. Yeah, so I know we don't have a ton of time left, but can you tell us about how you're going to maintain a control population of cells to make sure that we're adequately addressing the mutations inherent to aneurysms compared to just general heterogeneity in a genotype of endothelial cells around the body?
Yeah, no, that's a very important question. And surprisingly, these techniques have been around for some time, but, surprisingly, up until now, very few people have really used this to study aneurysm cells. And of course, one of the big questions is, right, you're going to come up with, 9 billion read from, X number of cells. How do you make sense of anything? One of the ways that we have internal controls within patients, so that, we take, other catheters, that are used in the coiling procedures, such as femoral or radial sheath, as well as the intermediate catheters that is sitting at the petrous ICA. And we take cells from these locations that would act as an internal control, because obviously, you know, genetically all these cells come from the same patient, but they are not in an aneurysm. So our hypothesis is that, you know, if truly due to hemodynamic changes, there are genetic differences, these may only show up in the aneurysms themselves. And if you like, you know, you look at the signature that is present in the aneurysmal endothelial cells, and you must like do a subtraction sum of, you know, the controls. And I think that acts as an internal control. And then again, because, you know, you're looking at one cell, you know, in the aneurysm, and this maybe allude to the work that Dr. Patel, you know, Sam and Abdullah are doing in gliomas. You know, how do we know that we are actually capturing the cells that are important for pathology within the aneurysm? We'll have the whole tissue aneurysm dome control, for which we'll perform a similar study with the sequencing and bioinformatics analysis.
That's great. Beautiful picture, Chris. Did you get this early in the morning when you came in? Not today, though.
Not today. I think this was probably like, you know, one of these like Sunday mornings, you know, on call at Harvard as a R2 or something.
Yeah, very good work. Thank you. I want to just say a comment to all the residents. I am really impressed, and you've taken on this mantle of research with a passion, and you're at the right place. You are in the right place with the right mentors and the right intellect you all possess. And I expect great things from all of you, and you're producing. So thank you, thank you, thank you. All your faculty and mentors, thank you for being so excellent. If Mike didn't meet your expectations, I want to thank Dr. Levitt for really being the brainchild behind these research symposiums, and Dr. Ojiman, who I think is on vacation, Junior Ojiman, not the senior Ojiman. Mike, any last minute comments?
I think that, and thank you, boss. I think that the need to get together and describe to your peers any of the research that you're doing, whether it's a main overarching funded project or a smaller case series or case report, not only gets you into the mindset of presenting research, which is a skill that's separate from doing the research, but also forces you to organize your thoughts in a cogent and concise way. And these are skills that will aid in the production of the research in the future. So it's a meaningful exercise just in general. And I think our residents show the diversity and breadth and depth of their expertise and interests. And I think it's been a great experience.
Thank you, Michael, for the last word. And Dr. Durfee, we'd be remiss if we didn't thank you for all the work and help you are giving our residents. Thank you. Everybody have a beautiful, beautiful day.